Okay. Hello, everybody. It is Airway Day today, and so we're going to head and get started with our next lecture in our series, which is the airway. I think something that causes a lot of anxiety in people dealing with trauma, and especially combat trauma, is the airway. So, like, what are we talking about? What does that mean, and what do we do about it? This is what we're going to talk about today. Let me move my face out of the way. As always, like I know this may be boring for some of you, but it's actually really important. The lit review of how important is airway obstruction and why are we teaching it. I'm not training you to be supplemental oxygen monkeys. We're training you to be thinking healthcare operators, and so the why is the most important thing. If you know why you're doing something, you'll follow somebody to the end of the earth. But if you don't know why, you won't follow them, across the street. What is the airway? How do I assess the airway? And then the teacher will see airway interventions and then supporting data from those. All right, good news first. This is overall survival rate of casualties in global war on terror, 90%. All right, that's pretty awesome in time when the weapons have only gotten more dangerous. We've gotten the highest survivability. Vietnam was 84, World War II it was 80%. So we're getting better. We're getting better at this stuff. We're getting better at treating combat casualties, despite maybe all the doom and gloom data I've shown you. Will we continue to get better? I don't know. Maybe. What about large-scale combat operations? That's what LISCO stands for. You'll hear about near-peer conflict, asymmetric warfare, low-intensity conflict. And some of these will do better than we are now, and some of them will do much worse. Some of the estimates on large-scale combat operations talking about tens of thousands of casualties each month. We're not even designed to fight that way right now. And so we need to be as good as we can right now for what will happen tomorrow. Okay, for lit review on airway, we're going to go back to this paper that we've looked at basically in every presentation. Sorry, I keep moving my face around. Death on the Battlefield by Brian Eastridge, Mabry, and colleagues, 2001 to 2011. And we're not looking at it through the lens of massive hemorrhage anymore. We're looking at it through the lens of how big of a problem is airway obstruction in preventing preventable death on the battlefield. Nope. And this is Journal of Trauma and Acute Care Surgery, 2012, Iraq and Afghan combat deaths, 4,600 deaths. And these were evaluated by the Office of the Armed Forces Medical Examiner. 87% mortality was pre-hospital. Okay, so most of these people died prior to getting to an MTF. The Armed Forces Medical Examiner determined on autopsy that basically 75% of these casualties were non-survivable injuries. We're not even looking at those. There's nothing you can do about that. The greatest combat medic in the world couldn't do anything about that. 24% of those are potentially survivable. That's really what we're looking at. That's the number that we're examining in depth. If you go into the nitty-gritty of this paper, it actually even goes into the time frame of death in the battlefield. 35%, I don't know if this is like a reassuring phenomenon if you were to die a combat death, but 35% is instantaneous death. Maybe a nice way to go. 52% is acute minutes to hours pre-hospital. And then really only 13% of these people that died, only 13% of this 24%, if you want to think of it that way, that's not quite how the stats work, died after reaching a treatment facility. So most people are dying in the pre-hospital. Potentially 65% of these fatalities we have a chance to intervene on. That's this 52 plus 13. Not quite. They didn't really break down the time of death in non-survivable versus potentially survivable injuries, but there is a large percentage, this basically a third, over a third, that is instantaneous death. There's not anything anybody can do about that. Okay, this is a great graph from this. So we're going to talk about the most. What do we die of on the battlefield? This massive number here, hemorrhage is like 91% of all the people. And then down here, this airway obstruction, physiologic airway obstruction. That's number 2, and then tension physiology, tension pneumothorax is number 3. 91% is hemorrhage, 8% is that airway compromise, and then 1% tension pneumothorax. So I think tension pneumothorax is certainly a sexy topic that everybody wants to talk about. Needle decompression, finger thoracostomies, chest tubes, blah, 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 chest seals. It's very low risk phenomenon, but it does happen. All right, and everybody's eyes are glazing over from the lit review, but a couple more things. This is like the second most common preventable cause of potentially survivable death is upper airway obstruction caused by injury to the structures of the face and neck. Okay, so although it is only 8%, it is the second most common cause, so it is a big problem. It's something we definitely have to deal with. Many of the casualties in this study had also concomitant cervical vascular injury, so injuries to the vessels in the neck. And so something to remember that you can have massive hemorrhage and airway as a two-factor phenomenon. All right, what is the airway? What does that actually mean? People say that, oh, go assess the airway. Assess the airway. What does the airway say? What is that thing? It's two things. It's one, the anatomic structures required for respiration. My face holes, my neck stuff, and my lung stuff. The physical things, okay, is part of the airway. The other part of the airway is this sort of more nebulous concept, which is the ability of the person to breathe. How is their breathing? The effort of their breathing? Are they in distress? Do they have poor effort? The ability of the casualty to utilize those physical structures for normal respiration. That is an all-encompassing thing about the airway. It's kind of like, what is a person? I'm a person, my physical bones, my muscles, my skin, my organs, sure, I'm a person, but it's also like, what makes Sean Griffiths, like my personality, my feelings, my beliefs, my emotions, my, faith, family, house, my dog, like stuff also makes me me. And that's what the airway is, the physical stuff plus how to use that physical stuff, okay? All right, these are the pictures of the airway. Okay, so on the left you have your sort of nasal passages, your huge tongue here, the posterior oropharynx here, the larynx down here, which is where your vocal cords are, and the epiglottis, your trachea anteriorly, and then your esophagus posteriorly. And this is a view, basically this view right here is this view on the right zoomed up. This is your thyroid cartilage. This is the beginning of the trachea here. This cricothyroid ligament is where you will cut to make surgical cricothyrotomy. We'll talk about that later. This is a very significant component of TCCC airway anatomy. I have a model of one that we'll talk about later. We'll talk about how to do a cric. Looks like this. I will bring this up to drill one of these times here pretty soon and leave a couple for people to practice on. This is also the airway, okay? So this is the trachea. This would be the trachea that comes down, and this would be your main stem bronchi, which goes and goes and goes and breaks down into smaller and smaller and smaller passages, basically until you get all the way down to the alveoli, which is small, basically sacs that allows that respiration of exchange of carbon dioxide and oxygen. You would have a right main stem bronchi as well over here. So the airway consists of these physical face and neck structures as well as these thoracic structures. If somebody's having a problem at the alveolar level, you may deem their airway to be unsecure if they have hypoxia or significant respiratory stress or something like that. This is also up in the airway. This is, sorry, it's not a very high-res footage, but I think you get the point. There's a lot of blood vessels here, a lot of vascular things going on. That penetrating trauma or blast injury or certainly even blunt trauma can cause vascular injury to these major vessels in the upper chest, neck, and face. Okay, overall, the airway assessment is continuously changing, but it always ends in a binary fashion of the airway is either secure or unsecure. We cannot be wishy-washy about the airway because airway is a hard stop in our treatment algorithm. And so we need to know, are we good to go or are we not good to go? And so it is a continual assessment and it can change rapidly, but we need to give a go, no go with the airway before we move on. The airway is a fork in the road on your decision-making path, okay? And forks in the road, when you are approaching a fork in the road, you need to be awful sure about which way you're going to take because there are some things you can't come back from. You start cutting someone's neck, you're not coming back from that. Finish the cric. You push paralytic drugs and sedation drugs to intubate somebody, you're not coming back from that generally because you're not going to have reversal agents and things like that like you would in a civilian operating room. So you need to, the only way out is through. So as you approach a fork in the road on a decision-making path, you need to gather as much data as you possibly can before you take a turn on that road that you can't take back, okay? And so airway is a fork in the road. We need to decide on it before we keep going. We can't just go straight into this grass. We need to go left or right. Okay. When we're assessing the airway, what are some signs that there's like an insecure airway or something that's going to be bad? So there's some obvious signs. I think these are all relatively obvious if we gave somebody an option to say, hey, what are we looking for? Certainly respiratory distress. They're breathing super fast. increased respiratory effort. They have accessory muscle use. They look like they're struggling to breathe. Choking, gargling, sonorous respirations. This is a fancy word for snoring. Cyanosis, or they're in hypoxic respiratory failure. You put the pulse ox on them. Their pulse ox is 71. That's bad. That's not normal. That's a sign of potentially unsecure airway. Large facial or airway burns. That's going to lead to very significant swelling in the airway, making you at risk for airway obstruction. Any penetrating neck trauma, frankly, any penetrating neck trauma is putting you at risk for unsecure airway. And then probably the two most obvious, respiratory arrest and cardiac arrest. So maybe some more subtle or less obvious signs of potentially unsecure airway when you're doing your airway assessment on a casualty would be depressed mental status. They used to say the phrase GCS less than 8, then you should intubate. I don't know. That's like not a hard and fast rule. I think I tend to approach, now that I have a little more experience, I've been doing this for a while, I tend to approach people as they look like they need to be intubated or they don't. And then if I'm not sure, then I may calculate their GCS. But some GCS points are more valuable than others for reasons that may be dumb and relatively arbitrary. But a severely depressed mental status is not normal, and that should clue you that the patient may need to be have an airway intervention performed. Impending respiratory failure, which I've sort of sub-clarified as worsening respiratory effort, may be colloquially known as, or a layperson may say, guppy breathing. The person's looks like a fish out of water. They have poor drive. That is impending respiratory arrest. They have tired out. They are almost going to stop breathing. You need to intervene immediately. But they won't look as if they're in as much distress as someone who's breathing 50 times a minute. And then projected clinical course. This one takes experience. This one takes time to learn. Projected clinical course means, what does their future look like? This person's future is, hey, I don't know, the OR is 10 feet away. We're just going to roll to the OR. They'll handle the airway in the OR with their CRNA, with their anesthesia, whoever. A surgeon will do a emergent trach, and the airway will be secure. Or the projected clinical course is, I don't know, we got to transport this person by ground 3 frickin' hours to Baluchistan, wherever, and then they're going to get on a helicopter and fly another hour somewhere else to definitive care. So do I want to intervene on the airway now and make it so it is secure for that really dangerous transport, or do I want to leave that in the hands of somebody else? So projected clinical course is a sort of almost a tactical situation. All right. Basically, that says what I already said. It also comes down to a little bit of risk tolerance. Everybody's risk tolerance is different. You'll learn your risk tolerance when you've made mistakes. There's no experience like real experience, and sometimes you have to make some mistakes to realize ooh, maybe that wasn't the greatest decision. All right. I want to highlight this. There's a huge difference between what the JTS, Joint Trauma System, Department of Defense, Center for Excellence of Trauma, says we should do about airway, and then the real world that you live in, whether you live in Kansas, whether you live in Texas like me, whether you are a college student, or whether you are critical care, ICU, nurse, doc, whatever, in your civilian job. And so what the JTS does is they make things for all comers, and they make things streamlined and straightforward to remove ambiguity on the battlefield. Okay, and so what you would do in your civilian hospital or civilian EMS or whatever is going to be way different than the TCCC clinical practice guidelines, and they have to be because those environments are not the same. You cannot do things the same way. You don't have the same resources, you don't have the same time constraints, etc. So just know that this may sound different than what you've maybe been taught. All right, the TCCC airway algorithm. It's very straightforward. It's extremely straightforward. It's been simplified over the years, but assess for unobstructed airway. So basically look at those things that we looked at before. Place the patient in a recovery position or position of comfort for respiratory effort. They have clarified in previous statements that the recovery position is basically a head tilt chin lift, and see if that causes any relief of airway obstruction, or position of comfort. If someone has bleeding in the face or neck, often the position of comfort will not be laying supine, choking in their own blood. The position of comfort may be sitting up, sitting forward, letting any bleeding go forward. Do not suffocate them by laying a bleeding patient with a bleeding oropharyngeal wound on their back and making them drown. So you can sit them up. If these maneuvers are unsuccessful, perform a surgical cricothyrotomy. That's the entire airway algorithm. It's very straightforward, very direct, because they don't have time to assess the different nuances that you may see in any other situation, because there are tactical considerations, transport considerations, you have minimal supplies, minimal drugs. That's basically the whole airway algorithm. When it comes to crike, they have a couple more things to talk about. They want you to frequently reassess with pulse oximetry, that's SpO2, this EtCO2, this is end-tidal carbon dioxide, and then airway patency. Is the airway still good? This is part of that continuous assessment. That's binary, airway secure, airway unsecure. Okay. C-spine precautions are generally not needed for penetrating trauma only. For the most part, if you see a penetrating trauma to the neck and you do not suspect there's a spinal cord injury, you do not need to place a C-collar on. C-collar has some really annoying things about it when it comes to protecting the airway and manipulating the head and neck and manipulating the airway. So you don't need that if it's penetrating trauma in a trajectory that you do not suspect cause spinal injury. Like if the person's shot in the neck and they're moving all their arms and legs, they probably don't have a spinal cord injury. So you can hold off on the C-collar. That's the whole thing right there. That's the entire airway algorithm. You can look at the CPGs yourself. It's probably the shortest of all the sections on tactical field care. All right, these are massive changes from previous. I have some supplies here that I'll kind of show everybody, but these are massive changes. So bagging the patient with the bag valve mask, that's out. Things like this OPA is out. NPAs are out, okay? The eye gel is out, okay? I still have one of these in my aid bag that I keep in my vehicle. I don't know. I think there's a lot of reasons for this. They took a lot of them out. One, the eye gel had some problems, like environmental problems, not like tree huggers, but like the eye gel would degrade in extreme heat and things like that. The other supraglottic airways, you may have, these are gel, so they don't have to be inflated, but other supraglottic airways had to be inflated with air. And then at certain altitudes, like the pressure would go down, and so the airway wouldn't work anymore. And so they didn't like that, which is why we moved to the eye gel for a few years. But they also had problems with like major burns, and then penetrating trauma to the neck. Like this is an unsecure airway. This is not an ET tube, and so bleeding can go around this and cause asphyxiation and problems. And so they're saying that this is not secure enough to call an airway secure, and so the eye gel is out. So it really has streamlined this entire process. All these adjuncts in the civilian hospital are awesome. They're great in cardiac arrest. They're great in bagging. They're great in procedural sedations. They're great in surgery, whatever. But on the battlefield, they really don't have a place. These are just guidelines. You can operate outside these guidelines, but you operate outside these guidelines at your own risk. Okay? And of course, this is an endotracheal tube. We'll talk about that later. That is certainly not in the guidelines. All right, TCCC verbiage. How to crike someone. I think we're going to stop this video right here, and then when we pick up, I'm going to grab this guy and we're going to talk about how to crike someone. We'll talk just real quick about how TCCC says to do it, and then we'll go to how to do it practically. This is the direct quote that I pulled off the CPG website. Their primary go-to is recommended is bougie-aided open surgical technique using a flanged and cuffed airway, blah, 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 blah. What that means is you should probably use a crike kit. That is a industry standard, try not to use like a makeshift one or whatever. Use a bougie, which is a flexible introducer tube that you can put in to help aid intubation and aid crike. Make your cut, put your bougie in, and put your airway over that, and use a cuffed airway so that you can blow that up and secure the airway. And then the other option is a standard open surgical technique, which is basically they don't have a bougie in there. This is less good. This uses your finger, maybe more prone to cutting yourself or whatever, but less secure than using the bougie. Okay, bougie aided crike has a high success rate. Bougie aided intubation has a very high success rate as well. Okay, you always verify placement with end-tidal CO2. This is much more accurate than breath sounds. Okay, this is much more accurate than I listened over both lungs, I listened over the stomach, I didn't hear any air. That's a bad idea. That's dumb. We have better technology now. Always verify with end-tidal CO2. And then if the casualty is conscious, they recommend lidocaine. That's straight off their website. that is all their tips. I have a few more than that, but we're at our 20-minute mark, which is a semi hard out for me, and so I will stop this video here, and then we will pick up on video number 2 with how to perform a crike, and then some really damning data about how we're not that good at this in the American military. All right, thanks guys.